Okay, we're going live. All right, welcome in to our Friday morning webinar. Just let people stream in. And as you enter into the Zoom room this morning, I'll ask that if you're comfortable, in the chat box at the bottom part of your screen there on the bar, you can pull that up and say hello, good morning, and share where you're joining from. And we can see all the people that are going to be joining this morning. Good morning, Duncan. So Duncan's joining from Regina, and Patty is from Kelowna. Oh, you have family in Victoria. Duncan, nice. Thank you for joining. We have Prince Rupert, North Vancouver, Powell River, Duncan, BC on the island. Vancouver Island and Vancouver. Wonderful. Thank you. Thank you for joining, and thanks for interacting in our chat. Good morning. Thanks, Irene. Yes, this will be recorded. So if you have to jet at a certain time, not to worry, we'll send you the recording. Wonderful. Thank you for joining. So this morning we have Dr. Daren Heyland, and he is here presenting on advanced serious illness planning and preparing for the unexpected, which I feel like is a timely, unfortunate, but also a great time to discuss some of these topics. And Dr. Heyland is a critical care doctor, a medical researcher, and a professor of medicine at Queen's University in Kingston, Ontario. And he serves as the director of the Clinical Evaluation Research Unit at the Kingston General Hospital. And he's also a champion of person-centered critical care, and has over his career developed a number of decision-making tools, which you're going to get to explore and chat with him about today. So welcome in. I'll get you to move it forward just to give a little understanding of how this is going to work this morning. You are muted and your cameras are going to be off. And at certain points, you'll be prompted to have some feedback or some answers to specific questions in the chat box at the bottom that you just used. And there'll be a time at the end for Q&A. So there's a Q&A button that also you can use to put your questions, and we'll get to those at the end or at certain points of the presentation where it fits. So thank you for joining. And a moment to acknowledge the land and that you're on. And I'm going to thank the land that I'm joining from is the Lekwungen speaking people, also known as the Songhees and Esquimalt people. And for taking this time to just acknowledge the land that you are joining from, that you work on, that you play on. And yeah, thank you for that. And if you're new to Family Caregivers of BC, we are a nonprofit charity, and we're dedicated to supporting family and friend caregivers. We are have been around for, it should be 32 years now, and we're the first of its kind in Canada, and only 3 provincial organizations across Canada. So we're very much committed to supporting caregivers in British Columbia. We have specific pillars that we offer caregivers, one of them being education, such as today. We have caregiver support, which comes in the form of support groups, our toll-free caregiver support line, and engagement and collaboration that we have with healthcare providers and other organizations. Great. And so to set the stage this morning of what Daren's going to be discussing, I thought it would be important to share the definition of advanced care planning in BC. So advanced care planning is the process of thinking and writing down wishes or instructions for present or future healthcare treatment in the event of becoming incapable of deciding this for yourself. So it's important to have conversations with close family, friends, and healthcare providers so that they know healthcare treatment that you or the one would agree to or refuse. An advanced care plan should include information for a variety of situations, including hospital care during and after routine surgery, care in the event of an accident, or end of life decisions. And so I'll hand it over to Daren to share his knowledge. Thank you, Daren.
Thank you, Kate, and thanks for giving me the opportunity. And certainly COVID has created some anxiety in many of us about health and what might happen to us if we were to get sick. Maybe you're not so concerned about yourself if you're a younger person, but there certainly might be older people in your circles where if they were to get a severe COVID infection, what would happen to them and how would they turn out and who might make decisions for them. And so this concept of advanced care planning is super important given the context of what we're living through right now. My goal today is to talk a little bit more about your definition of advanced care planning and how that might differ from the language that I'm using. And I'm being very intentional when I talk about advanced serious illness planning. And I'm going to highlight the last 20, 25 years of my career where both observing clinical practice and researching that space of communication and decision-making has led me to conclude we need to do something different. And my offering is advanced serious illness planning, and I'll introduce you to a service called PlanWell Guide, which is free, that enables people to think ahead and plan ahead for serious illness. And I'll emphasize how different and distinct that is from planning for end-of-life care. And part of my interest in getting in front of you is to educate and explain, and then invite you to help me get the word out and to just share knowledge of PlanWell Guide with your friends, family members, and if you're here in some sort of a professional capacity, through that capacity as well. Just a little bit more about myself. So I'm a critical care doctor. This is the space that I work in. You can appreciate we're making life and death decisions around the use or non-use of technology in people who are super sick. And 95% or more of the time, we're not actually talking to patients. We're talking to their substitutes or their representatives or their proxies. I'll use that word substitute decision maker to best represent that. Usually a family member that has to step into this space and make very difficult life and death decisions. And the research and my own anecdotal experience over 20 years tells me or leads me to conclude that people arrive at this space ill-prepared to serve as that proxy. And they experience tremendous stress and anxiety, not just in the short term when they're making those decisions, but months, if not years later. I'll never forget an experience I had when I was attending in the ICU, and I was called down to the emergency room because an older gentleman was in extremis, and to me, it looked like he was dying imminently. And there had to be a decision made to escalate his care and put him on life support treatments, and he would need an urgent operation versus just palliate. And in the first minutes of meeting his wife, needed to make a decision on which pathway we go. I worked with her, we made a decision. The man ended up dying under palliative care. And I left the emergency room and went on to the next patient and the next thing I had to do. And then 6 months later, I get a phone call from this woman saying, "Dr. Heyland, do you remember me?" No, not really. Do you remember so-and-so? We talked about it met you in the emergency. Oh, yeah. Dr. Heyland, did we do the right thing? So 6 months later, she's still stressed and anxious about what decisions we made, as she was forced into that role of being a substitute decision maker and ill prepared for that role. And not only is this a problem for family caregivers who are stepping into that role of substitute decision maker, but it just because everybody who enters in this space is ill prepared, it leads to a lot of medical errors or people not getting the right medical treatments. And here's just 3 different studies, 2 of which I've done, that document older people in ICU who prefer comfort care are in the ICU, signed up for life-sustaining treatments, spending an average of 10 days in an ICU before they succumb, before they pass away. And these are people whose values and preferences were consistent with comfort care. Or other studies of hospitalized older patients where we ask them about their preferences for CPR, and then we go to the medical record and we check, and they only agree, or they don't agree, a third of the time. And so there's the tremendous variability rates of error from 14 to 82%. And then an insightful audio recording of analyses between family caregivers and ICU doctors in family rooms where they're making goals of care treatment decisions. And very few times are patient values and preferences part of that dialogue. And only 8% of the time are those treatment decisions being grounded on those patients' values and preferences. And so whatever we're doing right now to try and improve the quality of decision-making around the use or non-use of life-sustaining treatments when people are sick and can't speak for themselves, I don't think is working. And I'll summarize, the message here that if you don't plan well, you're more likely to receive wrong care. You're more likely to receive an intensification of care, and the people involved in that space making decisions for you are most likely to have a difficult time, a very stressful time. Here's an anecdote of a woman who I wrote an article for a local paper regarding this issue, and she wrote me and said, almost a year ago, my husband died in my hospital of lung and heart disease. He was 78. I recently read your article in our local paper. I am one of those who is still suffering from having to see my loved one have to endure the pain of mechanical ventilation when he should have been offered palliative care. Someone in emergency should have known that we needed this based on the medical evidence and his history of many admissions over the past year. So a couple of things that really, stood out to me because, she's a year later, trying to deal with this and still suffering the grief and the distress of the medical care that she was expecting. And the other key point from this anecdote is that there's an expectation that you all have of lay people coming into a healthcare system that things will work out for you, and that the doctors will know what's best for you. And I guess part of what I'm trying to do with Plan Well Guide is empower you to have a better understanding of this space so that you can best help navigate that space yourself or with your loved one advocating for you. And I'm not trying to besmirch my colleagues or the healthcare system, but not to totally depend on them that all things will work out right for you. You've got to invest in yourself and think ahead, plan ahead, and then be ready to engage in serious illness decision-making to get the medical care that's right for you, or capacitate your loved one so that they can best be a proxy for you. So I've been working in this space for more than 20 years. I go back to the founding days of the Speak Up campaign, working with Canadian Hospice Palliative Care Association, trying to promote getting the conversation started. But the problem was back then that we were framing it around end-of-life care. And I'll never forget an experience I had when interviewing a lay person in their home, an older woman, and I was trying to get a sense of their perspective on this planning space. And immediately as we got into the topic, and she understood what I was after, she says, "Oh, I never want to be on machines." And I tried to explore with her, well, what if you just had pneumonia and there was a probability that you were going to recover and you could get back to how you are right now, today? Would it still be worth going on machines? And her countenance changed, the firmness in her voice and the assuredness of her speech changed as she then looked at me with some quizzical look and said, "Well, I'm not sure. What do you think, doctor?" And what I'm trying to illustrate here is the difference between a person who says, "When I'm dying, I don't want machines. I just want comfort only," from the scenario which 99% of people face when they're seriously ill is, there's a probability that you could recover from this, but there's also a probability that you could die. And so how do we make decisions under those conditions of uncertainty? Or said differently, what relevance do these end of life plans made under conditions of when I am dying have to serious illness? And so that's one of the reasons that I'm shifting away from the language of advanced care planning, and which is framed around end of life care, to advanced serious illness planning, which has a better connotation, a better understanding. COVID, pneumonia, getting hit by a bus, having a major stroke, lay people understand that they're going to be ill, that there'll have to be decisions being made, but it's not framed around end of life care. Framing around end of life care is also a barrier. I'd like to talk a little bit about why lay people like yourselves don't engage in this kind of thinking ahead and planning ahead. And please, if there's other ideas on what your barriers are, or what your barriers of your loved ones, or maybe it's your older parents that you're worried about, and why don't they engage in this space, please put it in the chat. I'd love to hear some more ideas. But here's what our research shows, that actually framing it around end of life care is a barrier, because even older people don't want to enter into that negative space. And they say, well, I'm healthy now. Why would I plan for my end of life care? Much easier conversation to say, even though you're healthy at 83, you could get pneumonia, you could get COVID, you could get hit by a bus. And so you won't be able to best represent yourself at that time. And so it'd be a good idea to do your advanced serious illness planning just in case something untoward happens. And that's a more socially acceptable response when you start to frame it around serious illness and not death and dying. A lot of pushback I get from families, or patients rather, in terms of leaning into this space is, well, it's not that stressful to me, or not that important to me to, find a substitute decision maker and tell them, what's important to me, because they know me, my family know me, they'll do right by me. They know me well. And here's a quote from a critical care doctor that says, "I can't tell you how many times I've been in a family meeting explaining the poor chances of a good outcome of a critically ill patient who is now unable to speak for themselves. And I look to the family for input, and they say something like, 'Oh, we've never talked about this. I don't know what the patient would have wanted.' And that anxiety and stress is palpable." So despite having a loving relationship and being well known by your family member, that doesn't enable them to make these kinds of specific inputs into stressful life and death decisions. So just because they know you doesn't mean they're prepared to represent you in this space of life and death decisions. Other people have other barriers related to their family, that their family situation is too complex or chaotic, or they don't communicate well. And so they don't want to go there. They don't want to, have those awkward conversations. And then I got a quote from a litigation lawyer, and I won't read the whole quote, but you can just imagine that if you don't resolve these uncomfortable, chaotic family difficulties pre-incapacitation or pre-death, it's only going to get worse when your voice can't be heard and they're struggling in their chaotic, dysfunctional way to resolve complex problems. And that's why a lot of these situations, whether it's related to medical care or personal care, end up in courts. And families spend a lot of time and money litigating, trying to resolve them. Oh, if it could only have been addressed, pre-death. And so the voice of that person who's no longer able to be heard could weigh in there. And so that's not an excuse to not lean into this planning space. Another one I love is people who say, well, I don't think this is important. If it was important, why wouldn't my doctor bring it up? I heard that a lot. And it's unfortunate that the doctor doesn't bring it up. In fact, we audited hundreds of older patients in hospitals around Canada, and we asked them if they had talked to their doctor about their end-of-life wishes, their values, their preferences, the things that were important to them. And less than a third spoke to any healthcare professional, be there a doctor or a nurse, in the hospital. Since we had just elicited their values and their preferences, we then again went to the medical chart, and those preferences agreed with what was recorded as the order for the use or non-use of life-sustaining treatments only a third of the time. So if you rely on your healthcare professional to do what's right for you, and they don't talk to you, you're only going to get a 1 out of 3 chance of getting the medical care that's right for you. So we were astounded by these findings. And then we went off and we surveyed over 1,200 doctors and nurses working in acute care, asking them, why are you talking to these high-risk patients who are very vulnerable, very sick, where the issue of going to ICU or being resuscitated is super relevant? You can't tell me it's not relevant, because there's sick older people in hospital right now. Why aren't you talking to them about their goals of care? And this is what I'm showing you here are a list of potential reasons, barriers, why doctors and nurses don't talk to their patients about this. Number one reason is patients and families don't seem prepared to discuss this with me as a doctor or me as a nurse. They don't know enough, they're not accepting enough, they're not ready enough. And there's a list of other barriers there too, but based on the rankings, the most important things seem to circle in on, this preparedness feature. Well, it was at that point in my career that I pivoted away from training healthcare professionals on how to have serious illness conversations to, what can I do to better equip lay people to understand this space, to accept this space, to better prepare for this space, so that I reduce that barrier, so their doctor or nurse will more likely to engage, and they'll have a more fruitful conversation. So I started talking to lay people. How can I help you better prepare for making decisions in serious illness? I was shocked with the early responses that I got from people. They would say things like, well, I went to my lawyer. I filled out those forms. Therefore, I am prepared. And I just, want you to think about how sensible that is to do, healthcare planning with legal professionals. It's about as sensible as putting me into a courtroom to try a case of someone that's, disobeyed the law. And so how do we get lawyers out of the healthcare space and doing what they do best and doing health planning with doctors? And oh, by the way, the actual process and the forms that they use are not that helpful, because frankly, the legal forms in most provinces are still framed around end-of-life care. When I am dying, the lawyer writes in a form, a representation agreement, that this is the treatments that I want or that I do not want. And again, the issue is that at the point where I don't know if you're dying, I have to make treatment decisions. And so any document, be that a legal document, an advanced directive, advanced healthcare directive, a living will, or your own chicken scratch on a piece of paper that says, if I am dying or when I am dying, this is what I want, this is what I don't want, is not relevant to the conversation we're having today. It's not relevant to the scenario when you're sick, hit by a car, had a stroke, got COVID pneumonia, and you can't speak for yourself, and you need someone to represent you, because those wishes framed under conditions of certain death cannot apply or do not apply, or rather they have to be translated by the substitute decision maker and the doctor. And that translation results in guessing and stressing. And after doing that for so many years and realizing, oh, I've got to translate what they said here about, when they're dying to the current scenario where they're not dying. Did they know that when they said they refused heroic measures, that 24 hours of positive pressure ventilation and a squirt of Lasix, and I can get them off these machines that we're talking about here? I'm confident that they didn't know that when they said in their wishes, I don't want machines. And so we end up disregarding those wishes written under conditions of certain death, and the poor substitute decision makers like, oh, because they have this document that says no machines when I'm dying, and you got this doctor saying, well, I'm not sure if they're dying, and I think we can't have this unsuredness about what to do, so we go and intubate and send them off to the ICU. So that scenario repeats itself day in, over and over again in ICUs around the country until, hey, we got to do something different. We got to do something different in the way we approach this planning. I'm going to skip that slide. And so what I'm summarizing here is the traditional view of advanced care planning, where it just focuses on the conversation, getting you to open up and start talking about death and dying to your loved one. And then in a way that's good, but I'll stress through the rest of this presentation that it's more than just a conversation. I need to prepare you for medical decision-making. That has a higher educational requirement, a higher willingness to lean in and learn about serious illness decision-making. I've already made this point that advanced care planning traditionally is all focused around end-of-life care. And I know you can point to in your definition of advanced care planning in BC, oh, no, it includes hospital care or what to do with, if you become seriously ill. That's what you as a professional body might articulate. But when you talk to lay people on the street, everybody associates advanced care planning with end-of-life care, end-of-life planning. And frankly, that's how it was rolled out for the first 20 years in Canada. So you may change your definition, but it doesn't change the way people operationalize their views towards it. And thus, it's still a barrier being framed around end-of-life care. The other thing that I'm going to take exception to is traditionally advanced care planning has been, because it's all about the conversation, it's all about just talking about death and dying with your loved ones, that it can be done without any healthcare input. It can be done by lawyers, as I've already talked about. And well, I'm trying to say advanced serious illness planning is a bit more sophisticated than that, because we are trying to help you understand a very complex space where decisions about using or not using life-sustaining treatments in the context of serious illness are being made. And so, we need a little more sophistication in how we explain terms and processes and outcomes. And I don't think this is a lay person coaching another lay person. I think this requires a higher level of input from healthcare providers, or as you'll see with Plan Well Guide, virtually I can do that as a healthcare provider, on a website. And I want to come out and categorically say that I think end-of-life planning, which is relevant and helpful for people who are at the end of life. So if I have advanced cancer and I'm trying to predict and ensure what my final runway and landing looks like, end-of-life planning is important, but it probably isn't done with a lawyer. It probably isn't done with a lay facilitator. It's done with a doctor and healthcare forms, not legal forms. Healthcare forms, like your most form in BC, would be the form that would get filled out to codify that end-of-life planning. But that end-of-life planning has no relevance and is actually harmful to serious illness planning for reasons I've explained, right? Because we have to make those translational steps into the context of serious illness. So we need to stop doing end-of-life planning if you really mean to do serious illness planning, and do serious illness planning for serious illness planning. Fortunately, serious illness planning can be applicable to end-of-life scenarios because, again, we've codified people's values and preferences in a way that decisions can then be made even at the end of life on those values and preferences. So this is a really important summary slide, and I'll come back to hitting some of these points throughout the rest of the presentation. And again, love to get the feedback from you in the chat room or at the end when we have time for questions. And so I've tried to say so far, as a critical care doctor dealing with serious illness, that we need to reframe this conversation we're having about thinking ahead and planning ahead around serious illness. So I call that advanced serious illness planning. Now I'm going to share with you some of the challenges I have in dealing with a lay audience with doing this advanced serious illness planning. When I get into that subject and I ask people what they want when they're seriously ill in terms of their medical treatments, when I'm trying to elicit preferences, again, the majority of them say to me, and they kind of look at me funny, like, well, why wouldn't you just keep me comfortable? Because again, what they hear is, what kind of treatments do I want when I'm dying? And so I have to stress a lot on the website, on the Plan Well Guide materials, this difference between terminal or end of life care and serious illness, because it's not an easy paradigm shift for a lay person to make. They get death and dying. They've been conditioned for the last 25 years to worry about that, to try and control that. But that's not what I'm talking about. I'm talking about a scenario where you get a bad COVID pneumonia or have a major heart attack where we don't know what the outcome is. There's a probability that you could die, but there's a probability that you could recover. The issue is you won't be able to speak for yourself. And so I need somebody to represent you and understand what your values and preferences are so we can make medical decisions together. So when they start to sort of, understand that point and they come along with me, and so I come back to this question, so what would your preferences be? The next most common response that I get is, well, that depends. It depends on how I'm going to turn out. If I'm going to turn out fine, I want you to do everything. If I'm going to turn out poorly, just leave me alone, keep me comfortable. Well, gosh, you see how problematic it is that I can't deal with conditional statements like, it depends on how I'm going to turn out, because I can't tell. I don't have a crystal ball. I don't know at the point where I have to make a decision about using or not using life-sustaining treatments. I don't know how things will go. I can give you my best guess. I can talk about prognostic information, but I can't tell you for sure how you're going to turn out. And I like using this analogy, and maybe those of you who live on Vancouver Island will appreciate this, but I'm sure every morning you look at the weather report or on your phone or listen to the radio to get a weather report, because there's a high probability of rain, chance of thunder showers. There may be language like 60% probability of rain, chance of thunder showers. So what does that mean? Does it mean 100% sure it's gonna rain, or zero? No, it's not gonna rain. No, it's somewhere in the middle, and you don't know, but you still have to move forward. You still have to make decisions about whether you're going to go through your day, carry an umbrella, wear a raincoat, or just stay at home today based on that probabilistic statement. Well, that's very much like it is in medical decision making. We don't have certainty of outcome. And so if you keep framing this around, well, it depends on how I'm going to turn out, you're not going to be able to move forward and work with doctors to make the best medical decisions for you. And so we try and pivot away from, how am I going to turn out, to trying to ask questions about, well, what's important to you, and elicit your values and preferences just to inform medical decision making. But the fact is that we're not making medical decisions in our form of advanced serious illness planning. There's no medical decision making being made. Rather, we're preparing you for future medical decision making by explaining to you concepts like this, that medical decisions are actually a function of the person's values and preferences combined with the medical context, the problem. Is this sepsis? Is this a heart attack? Is this COVID? And therefore, what are the probabilities of outcome, good, bad, or ugly outcome, particularly given the patient's values and preferences. And that involves a conversation with the doctor where, under a shared medical decision-making model, that person, be it the patient or their substitute with the doctor, makes the decision and the person gets the medical treatments that's right for them. So that's the educative experience in Plan Well Guide, is to help people realize, oh, in the future, it could be tomorrow, right? Could get hit by a bus tomorrow. It could be next week. I could get COVID. But in that future space, I'm going to go through this process, make a decision, get the medical treatments that are right for me. And if I'm well enough, now I have, because I I know what my values and preferences are. I've got a script that I can follow, that I can engage with a doctor to get the medical treatment that's right for me. In contrast, if I'm not well enough, which is 90% of the case for older people, then I've got a script that my loved one, my substitute decision maker, can make for me to make the medical treatments that are right for me. So that's, again, an important distinction between traditional advanced care planning, where it's all about getting a person to say in advance, this is what I want, this is what I don't want. We're eliciting preferences, but we're not framing it around decisions being made. There are no legal ramifications. There's no medical decisions made here. This is just preparing people to be able to articulate their values and their preferences. Now let's go a little bit more deeply into what we mean by values. And I think probably most of you on here will appreciate that, values represents, things that are intrinsically important to people. And we as healthcare professionals try and give consideration to those values when recommending or helping people decide about these very difficult decisions, end of life decisions, or decisions to use or not use, life sustaining treatments. And so whilst there may be a whole broad set of life values, as physicians, we're interested in the values or their values questions that help inform us or give us a sense about what medical treatments, might be right for said individual. And so I'm just giving you some examples of, the kind of value statements or value questions that might help me guide, treatment decisions. So if somebody said, I want to avoid symptoms at all costs, quality control of my symptoms, being pain-free, that's the most important thing. I might recommend that we not have a trip to the ICU and have a tube put down every orifice in your body and support you in bed, under these difficult circumstances, for example. Whereas if somebody said to me, I want to live as long as possible, well, then I may be in that frame of mind where I'm recommending that we go to the ICU and we try life-sustaining treatments to keep them alive as long as possible. So these value statements inform treatment decisions. The challenge is that mostly people don't understand that there's a conflict between different value statements. And I'll remember an anecdote of I was caring for an older woman who had pneumonia. This is before COVID, and just community-acquired pneumonia, very serious, multi-organ failure, on a breathing machine, on powerful medications to support her blood pressure, kidneys starting to pack it in. And I'm trying to say to the daughter, who's the substitute decision maker, things don't look good. Worried about your mom. She may not survive. Trying to make a decision here about, how far we go with this. And the daughter says, my mom's a fighter. She'd want every kick at the can that she could have. And that's a value statement. And I can't argue with that. It's a representation of who her mom was. And so I may stop the conversation there. And in my head, I would translate, oh, okay, she wants to live at all costs. And then I may go to the medical order and say, okay, full intensive care, continue ongoing life support treatment for CPR. And you might think that's the right decision given the context and given the statement. But what's missing in that conversation is the competing or the value that's being traded off there for living at all costs impacts negatively quality of life, quality of existing life in ICU. And even if you survive, the quality of life of your residual life. There's that trade-off between how long you live and how well you live. And I'm trying to illustrate it in this crude slide with quantity on the x-axis, quality on the y-axis, and we all hope that we live a high quality of life until death, but the majority of us actually, as we live longer, we will suffer more decreases or reductions in function or decreases in our quality of life. And regrettably, there are some people that many survivors of ICU who end up in a health state that's worse than death. They're alive, but because keeping them alive resulted in a reduction in their quality of life, now they're alive, but perhaps not independent, perhaps not with clear thinking, perhaps in an institution, perhaps bedridden. And so, right now we're making those decisions agnostic or ignorant of the consequences of those decisions. And so as we study, optimally how to make better medical decisions, we need to, when we elicit values from people, try and make the competing values very transparent. And so these are the scales that we use in PlanWell Guide, where we're trying to say, today, given your health state, tell me what's important to you. Are you the kind of person that, it's all about living as long as possible? Or are you the kind of person where it's all about quality and maximizing quality of your remaining time? Now, if you were a young, healthy person, you'd find that question a little odd and say, well, I want to live as long as possible. But when you get into your older days and you're already suffering, maybe even barely hanging on to independence, to you, it becomes quality as the prime driver. You'd rather die sooner than live longer in that health state worse than death, right? And so, but in the way we ask the question, you see that trade-off. You see that if I sign over here, I'm giving up this. Or if I sign over here, I may be giving up this. Okay, so we make that trade-off transparent. In a similar way, we ask the question about people's willingness to undergo machines and admission to ICU. And tell me what kind of person, are you the kind of person that would be okay with this? Or no, at all costs, I don't want that. And then the value of asking those questions in that way is that we can then put that together. Slide was hidden. Anyway, I'm sorry, there's a mistake in my slides. And so there was a little animation where I would take these value scales and make a grid out of them. And I'm able to best indicate in a very transparent and reliable way what medical treatment might be right for them based on the answers to their values questions. Okay, and maybe at the end of the talk, I'll come out of presentation mode and show you exactly what I mean if there's some lack of clarity on that. But I use the values scales to indicate what medical treatment might be right for that person. And I emphasize the word might because people are really quite uninformed about the differences between, going to ICU or getting CPR, yes or no, or just receiving comfort care. And our own research has highlighted this. And let's use CPR as an example of this kind of, serious illness treatment decision. And we know that people, get most of their information on this topic from TV and consequently are ill-informed. We survey hundreds of older people in hospital who have CPR orders on their chart. And, none of them can really describe the process of what CPR is all about. And how many of them do you think can actually know what the chances of a good outcome are? And, so we asked them, well, of 100 patients like you who undergo resuscitation, how many think you will ever get home? And the right answer is less than 10. And 3% of people guessed that right. 63% of people said, I don't know. So, we're violating a healthcare law, the principle of informed consent, that before we sign people up to receive or not receive a medical treatment, we go through a robust process to help them understand the nature of the process, the risks, benefits, possible alternatives, and then we make an informed decision and then we sign up. So somehow, some way, the way the world works right now, we're having people sign up for CPR when they don't have any of that. They don't understand the risks, benefits, possible outcomes, treatment options. And so another big part of PlanWell Guide, this paradigm of serious illness planning, again, which is different than advanced care planning, which just focuses on the conversation. No, it actually, we're trying to prepare people to make treatment decisions in the future. And, and so we have a decision aid where we explicate all of that stuff about what is ICU, what is CPR, what is medical care, what is comfort care, what are the possible risks and benefits, how might that be right for you, what are the options? So that's a big part of Plan Well Guide 2, is to educate the consumer as to those different risks and benefits. So again, they're in a better position to make an informed treatment decision. So in summary, what I've been arguing, unfortunately, is current situation is pretty poor. Lots of medical error, lots of stressed out decision makers. People need more support in this space of deciding about not to or to use life-sustaining treatments, to go to the ICU, yes or no. And some of it is our own fault because we frame things around end of life. We frame things around conditions of certainty when in fact, operationally, we have to make these decisions under conditions of uncertainty. We treat patients as informed consumers and think that their wishes should be explicitly followed, when in fact they're ill-informed choices and they didn't go through an informed consent process when they express those wishes. And people may make value statements where they don't really understand the implications of them. And so, yeah, we need a different approach to say, would there, can we do this better? And I'm offering a Plan Well Guide, advanced serious illness planning, as a way of doing that. Just to give you a sense of the tool, there's different modules where you will be educated about the difference between terminal illness and serious illness. We go through a very structured way of helping you educate your on your authentic values and your informed treatment preferences. And then we go through that sort of value grid interaction, which unfortunately I couldn't illustrate, but it is on the website. It is in the pamphlet materials, where we can help you localize or finalize your medical preferences. And then we explain the concept of being incapacitated, where you're alive and yet not able to make treatment decisions for you. And so we get you to name someone and codify some values for personal care. This is, so far I've been talking all about medical treatment decisions, but there's also values and preferences for, if you're alive and not able to look after yourself, for personal care decisions. And so there's a component of that to the new Plan Well Guide. And then explain this concept of substitute decision making and get you to name someone if you haven't done that already. So that's what you can expect from engaging with the material. The output of Plan Well Guide is really two things: a Dear Doctor letter, the essence of which says, "Dear Doctor, I've been through this planning process. I know the difference between terminal illness and serious illness. Here are my plans for when I become seriously ill. Here are my values. Here are my preferences. Here are my reasonings. Here's my outstanding questions." And any open-ended text, things that person might want to say. Similar letter to the substitute decision maker. "Dear substitute decision maker, thank you for taking on this responsibility for me. Here's the things I'd like you to represent me by when making future medical and personal care decisions." So we think that's of great value to people. We're trying to roll this out, particularly during this time of a pandemic. I get frequently asked the question, well, I'm pretty well right now, but the answers to these questions are going to matter if I'm 20 years from now when I'm older, or later when I get sicker. And I'm saying, well, that's the nature of serious illness planning. You're planning for today, right? What if today you were to get COVID? If today you were going to get hit by a truck? What's the answers to these questions? What are your preferences? So that's how you respond to this. You're not planning for some future event. When you get hit by a truck at the age of 83, you're planning for today if you were to get hit by a truck. And if as you age or as your circumstances change, you can always come back and update your plan, right, as your conditions change. And maybe it is helpful for you to record some future health state that would not make it worthwhile for you to pursue intensive care. And so we do have a question like that, because people are worried about being kept alive in a future health condition. And so that future part is captured in one of the questions in Plan Well Guide, where we get you to, using your words, describe what that future condition is that you're super worried about. But the actual decision making is based on today. This is how I feel. This is what's important to me. This is what I think. Create the plan, live life. Don't worry about it. But if something untoward happens, you're prepared. If life changes, you get sick, you acquire cancer, you turn 87, you want to change your things, you can always do that. I'm just going to skip that question. I've already explained that. I'm just about finished, and then I hope we have some time for some questions. I want to say that not everybody wants to work on the web, and so we have a paper-based version of the tool, and that's downloadable on our resource page. What I'm trying to, invite you to do as individuals, or coax your clients or your family members to do, is to give up 30 minutes of your time to get the peace of mind that comes from knowing that you're prepared for whatever might happen. And again, what you get in return is you had deeper conversations with your family members. Those are enriching conversations for the most part, and they'll get to know you better. And so we encourage you to lean into this space, invest of yourself. It'll be worth your while. I'll just close with, another anecdote of a couple that came to a seminar where I was talking people through an earlier version of Plan Well Guide before I had the website. And about 5 or 6 months later, this woman or that was actually her husband, had an untoward event where he collapsed and sustained a significant head injury, and was whisked off to a hospital where, now he's on life supports with a significant head injury. And she and the children are meeting with the doctors to make these decisions. It was a difficult thing to go through, but made easier because they could hear his voice and had the Dear Doctor letter documenting his values and preferences. And so they made a difficult decision to remove the life-sustaining treatments and let him go, because they knew that he wouldn't want to live in that incapacitated state. And so she was grateful that she'd heard his voice and had captured his wishes, and it made a difficult process easier. So I'd like to invite you to engage with Plan Well Guide, promote it amongst the people that you circle with, whether that's in a professional or a personal way. I'd like you to also know I'm very approachable and I'm very open to feedback and comment. So if you have questions or comments about the Plan Well Guide, there's my email on the slide. Follow us on social media. Thank you very much for your attention. I think there's one question in the Q&A. So if you just pause for, maybe there's more than one. Okay. Let's see. Have you summarized those for me, or should I read them myself?
Yeah, I'm happy to. So the first one was around a family member that had severe mental illness, and that this person required acute hospital stays, and that they had a legal agreement to the rights to represent their child when he lacks capacity. But each time their voice gets ignored based on the argument that the Mental Health Act takes over. So basically, I think the question is what, the Mental Health Act takes over, and I just want to make sure I'm getting this correct. When do I know this better than the system? Like when can I advocate for my child, even though her son has signed an agreement allowing me to decide this when he can't?
Yeah, wow. I feel for your distress with that. That's a tough situation. I'm not the best person to answer that question. You're asking a question of capacity and a capacity assessment, and some of that is specific to that decision being made. And I'm not that. When you say the Mental Health Act, I don't know. I'm a simple critical care doctor, so I'm sorry. I'm sure Family Caregivers BC has other resources they can point you to help you answer that question offline. Sorry.
No, that's okay. Also, people are very curious and wanting to see, I don't know if you want to pull up, Daren, the value scales that you had. They were interested, or just knowing if that's on the website for people to see when they're going through.
So just give me a second. I'm going to come out of presentation mode. Whoop, what happened? It was the slide I wanted to show was hidden because it was animated, and I'm not sure. Anyway, so you can still see the slide.
Yep.
And so what I was trying to show you was those value scales, these ones. We take them and we make the X and Y axis of those scales become the X and Y axis. And then the answers to these scales, we find the intersection of them on this grid. And like I said earlier, that's indicative or suggestive. Don't think this is the answer, because again, these are ill-informed decisions that are being made. But it just, what it does is it reduces, it increases the transparency and reliability of decision-making. As I explained to you right now, the person says something, the doctor makes a translation in his or her head and off to write a medical order. Well, this tries to increase the reliability and transparency of it by connecting the answers to the value scales to a grid that makes that all transparent. Then you go through the decision aid and you better inform yourself what comfort measures, medical care or ICU care mean. And then you can, confirm that this is the right answer for me because now I'm informed. I hope that makes sense, but this is what I was trying to illustrate that I couldn't.
That's great. Yep. And many thanks in the chat box. We have a question from, it just disappeared one moment, from Anne. She said that her husband and herself have representative agreements and living will. And do you recommend that these be revised to address serious illness?
Yes, absolutely. I'm sorry, I don't have the representation agreement language memorized in my head, but if they're like any other province's language, they will have declarative statements such as, if I am dying, or if I am in a, vegetative state, or if I'm in any other, hopeless state, this is what I want and this is what I don't want. And what I'm trying to say is that's not helpful, right? Because decisions are made upstream of that before we know if you reach that. And so what I'm trying to work with lawyers is to remove that language and have language something like, my representative should engage with my doctor, make medical decisions based on my informed values and preferences as codified in the Dear Doctor letter, period. And then they can append that Dear Doctor letter to that representation agreement. And you've got the legal agreement that's important for naming that individual, but their operational guidance, the script that they should use, shouldn't come from a lawyer. It should come from a healthcare professional. And I'm offering up virtually, support you to get that script from PlanWell Guide.
That's great. I did my own PlanWell when I was getting ready for this presentation, and it was very intuitive. And I liked what you said in terms of, it was hard for me being healthy and able now, but you're right, considering it where I am now and then revisiting it at different times in your life to revise, I think that was a good takeaway for me. Barb asks, do you have one or two leading questions, conversation openers that have been effective in opening that door to talk about serious illness planning?
I imagine the context of there is, that some people face difficulty in talking, particularly to older people, older parents, older grandparents about, hey, and that's it. Instead of saying, what kind of care do you want when you're dying? It's like, geez, this pandemic is still around us, and lots of older people are suffering and being hospitalized, spending time. What would that look like for you, mom or dad or whatever, grandma, grandpa? And so putting it in the context of serious illness and COVID is a real conversation opener. One other comment I'll make is that we made a 4-minute YouTube video. It's called Acp Conversations. It's on our website. It's in the resource page. And I frequently say to people, just watch that with that person that you're struggling with. How am I going to have this conversation with? Just watch the video and say, hey, what do you think about that? Can we talk about this? Because on that video, we as critical care professionals are saying, we've got to talk about this. And we've got patients' voices represented and family caregivers' voices represented saying, we've got to talk about this. So it's a nice segue or opener to just watch that 4-minute video and then say, hey, what's your reaction to this? Hope that helps.
That's helpful. And I have another question just in terms of where the plan is stored. So in other words, this person doesn't have like where it can be accessed. And if they don't have any family, where would that live? There's a Dear Doctor and then the decision maker. If you want to speak to that.
Yeah, of course, substitute decision makers don't have to be family. I frequently use that term, but it could be a friend, it could be a professional trustee. And so it's up to you to decide who's going to be your substitute decision maker or who's your representative. The plan is stored in Planwell Guide. It's accessible there. So you create an account, you log in, you do your planning, it's stored there. You can automatically download it. So you have a hard copy on your computer. You can automatically email it to yourself or to your substitute decision maker. So you have copies there. But the value of having an account is you can go back in and change, update as things go. But you can take down copies and have access to them. You can't obviously adapt or update the downloaded copies because they come out as a PDF.
That's great. And Carly just put that video into our chat, and we put a few times your website. One last question, just being mindful of time. Someone asked, where does MAID come into this process?
Yeah, I get asked that quite a bit, actually. And I don't make reference to MAID in serious illness planning because I am trying to distinguish myself as not end-of-life care. MAID is part of a end-of-life care planning process, not serious illness planning. And currently, you can't plan in advance for MAID anyway. Imagine if that changes, then I might change my stance on that. But there is an open text box as you wind up the planning process where you can put in anything else you want your doctor or future decision makers to know about. And so if you're the kind of person that, if there's any question about the health state being less than acceptable, I would want MAID. That's not a legal declaration. It's more of an expression of a preference. And so you can put your leanings towards MAID or MAID-like treatment in there as open-ended box, but I don't address it formally in any of the content that I create because I'm about serious illness, not about death planning.
Wonderful. Daren, I'm just getting a lot of appreciation and thanks for this informative information, and someone that's worked in hospice for years and how informative this webinar has been. So thank you so much. Oh, someone just asked in terms of what is MAID. Do you know the acronyms?
Medical Assistance in Dying, legalized here in Canada a few years ago.
Thanks, Kristen, for that question. Wonderful. So all of you that are on today, and even if you've logged off, you'll get a follow-up email with Daren's resources, with some resources from Family Caregivers of BC. And Daren has kindly shared his email and his places that you can find him. So if there were additional questions that we couldn't get to in this hour, feel free to reach out to him or to us, and we're happy to support you. So thank you, Daren. I've loved this presentation. I've learned a lot myself, and yeah, thank you for sharing your knowledge and time with us.
Thanks for having me.
Okay, take care.
Take care.